Okay, well, this case is, one that just kind of presented a couple of wrinkles that I wasn't sure what to do with. Now, that A1C that's there is actually not accurate, but she is a 72-year-old woman um, who her A1C has gone up from 5.8 to 6.6 in the past year. Um, she is ready to treat her diabetes because she's actually takes pretty good care of herself, tries to keep up on what's happening. She's been doesn't if she wants to avoid complications of diabetes down the road if she possibly can. She's been hearing that Ozempic would help her with weight loss. But here's where the wrinkles come in. In January of this year, she got bloody diarrhea. Her hemoglobin dropped almost 4 grams. And the workup has shown that she has ulcerative colitis. Her comorbidities with the diabetes are long-term hypertension, hyperlipidemia. Her BMI is 36. She has reactive airways disease, and this positive PPD latent tuberculosis has turned out to be a wrinkle in the treatment of her ulcerative colitis. Because they're trying to figure out if they can suppress her immune system because of that. And she's got an ID appointment coming up over at UVA sometime in the near future, because that's where she ended up with her GI symptoms, because we live on the border. But anyway, her physical exam is pretty normal. Now, that A1C of 6.1 was better than the 6.6, which is her max. I misspoke a minute ago. That is actually the last one. But she's got this rapid red blood cell turnover because of the ulcerative colitis, and she's constantly making new red cells. So I'm not entirely sure how accurate that is. And I sort of feel like we should go on and treat her diabetes. But I hesitate to give, you can scroll on down, Mitra, because I think we can see the med list there. I hesitate to give somebody whose GI system is already in an uproar either metformin or something like the Ozempic. So I guess the question is, how do we treat this lady, and what can we get her that might have that side benefit of the weight loss? Am I going to worsen her GI symptoms, or am I overthinking this? So.
Thank you so much, Dr. Rexroad. We really appreciate you submitting this case and bringing it to the group here. Before we go into any of the recommendations, did anyone have clarifying questions about the case? And anyone is welcome to chime in.
Did you say the most recent was 6.1%?
It was. Her max had been 6.6. That was 3 to 4 months ago.
Okay. And I'm sorry, I didn't even see it on the list. Are you treating her with any iron at all?
She is not right now.
Okay.
I've been kind of leaving that up to the GI folks.
Yeah. Does anybody else have any other questions before I start talking?
Is she in an active ulcerative colitis flare, or did they feel like they got it under control since she got diagnosed in January?
It has waxed and waned. Right now, when I saw her 2 weeks ago, it was pretty decent. And she had just had the second Entyvio infusion, and she felt like that really was going to be helpful.
Thank you.
So, when I tend to have a higher threshold to treat when the patients are older. That being said, if somebody comes in and their A1C is above goal and they're 70, so if I had someone that came into my office that was 72, I'd probably use closer to a 7% or higher. But I know she wants to lose some weight, and Ozempic is really nice for that reason. So I don't think you necessarily have to treat it now if that's a concern. I think, I personally, I would not use metformin because of the diarrhea and the potential to make her stomach upset. Now, Ozempic could do the same, but that's, I'll have the pharmacy folks chime in as well. But from my standpoint, what I typically see with Ozempic is more nausea and less diarrhea, although I have had patients have some diarrhea. I think it would probably be more along the lines of some nausea. But I do think that if she wanted to try it for the weight loss potential, I think it would be reasonable to try the low dose. And you could even start her at the lowest dose, the 0.25 milligrams once weekly, and just trial it. And, normally when when you give that first pen, they do the 0.25 for 4 weeks, and then they go up to the 0.5. You could even just have her stay on the 0.25 until you see her again and see how she's doing. But I think if you're also worried about it, there's no rush to start treatment yet. So
she's kind of pushing me a bit. I mean, she is. So I'm like, you know what? I've got one who wants to acknowledge it and own it. I'm going to go with that.
Yeah, I don't think there's no contraindications that I'm aware of from the ulcerative colitis standpoint. I think you could just kind of preface it for her and say, look, the biggest side effects with the Ozempic are GI related, most commonly nausea. There is a potential for some diarrhea, but if you know about these and you want to try it, then we could try the lowest dose and then reassess. And if she's tolerating the lowest dose, I mean, she could certainly try to go up to the 0.5 milligram dose.
Okay.
So if she's pushing you, I mean, I definitely think it's a great option. And, the insurance may give you a hard time if her most recent A1C is 6.1, but you could also, I don't know if she received any blood transfusions around the time when she was in the hospital or in the time period between the 6.6 A1C and the 6.1. I don't know if she had any blood transfusions that would have caused it to be falsely lower.
Yeah, I can check on that. Is she one you would do maybe a fructosamine in because she does have the high turnover?
I probably wouldn't right now. I would just have her maybe finger stick and see what her blood sugars are, but the A1C hasn't been so high that I'd be immediately concerned about it. So I haven't done a fructosamine a lot. I mean, I know we have it available to us, but I don't know I think Dr. Perini's on here. I don't know if she would do a fructosamine, but I probably wouldn't.
Okay. I've had some other people that have been in situations where they've had high red blood cell turnover and we're not sure whether the A1C is active. So just kind of do the fructosamine to see how they compare.
Oh, definitely. That's a good situation in which I would do that. And I'm sorry, the timeline, she was 6.6 before the bleed.
I'm looking.
Sure.
And I'm happy to pull up the case again as well if anyone needs to.
Yeah. Well, I just she was 6.6 in May, which was kind of soon after the major bleeding.
Soon after. Okay.
Yeah.
And I'm wondering.
I don't think she got transfused. I don't think she had bled to that degree.
Okay. Has she been checking finger sticks at home at all?
Not a lot.
Okay.
It's hard sometimes to motivate people to make that step, even though they're motivated to do. She brought me a log the day she was here. She's checking over the last 2 months, maybe once a week. The highest I see on here was a postprandial of 194. Her fastings have been typically 120 to 140.
120 to 140. Okay. Yeah, I mean, she doesn't sound like she's having wide excursions in her blood sugars. And you could, I mean, if she wants to try, so sometimes we're trying to find ways to where we can use Ozempic, even if a person's sugars aren't horrible. And so if she's wanting to start it for the weight loss benefit, I think you with that 6.6 A1C, I think you could probably get it covered for her.
Okay.
But if she's very concerned about the blood sugars, I would probably just repeat her A1C and then see where it is, because her sugars sound like they're overall fairly well controlled. And the A1C of 6.1 now is really reassuring.
Okay.
I know that there's a couple of different ways you could go about it. So I hope I haven't confused anyone or.
No, I think you're giving me some things to think about, and
Yeah.
some things to go back and discuss with her, basically.
Sure.
And then we'll ultimately make the decision.
Mm-hmm.
And
And you could, I mean, now the more that we're talking about this, I'm sorry if I interrupted someone, but you could check a fructosamine level as long as she doesn't have any liver disease history. Then you can get a better idea given the, red cell turnover with the recent bleed. Wouldn't be a bad idea.
Okay.
I was just gonna say, I noticed Annie, you unmuted as well. Did you have a comment or anything?
I was just gonna say, like with GLP-1s, I was doing a little bit of like research into it, and there are some studies that look at the benefits of using GLP-1s in patients who have ulcerative colitis to like resupplement those hormones in the body, since they are deficient typically with ulcerative colitis. And there are some interesting studies going on to use metformin in the use of ulcerative colitis, but to me that doesn't really make sense, but they are in the clinical trials, just to let everyone know.
It's indeed interesting.
It is interesting.
Would an SGLT2 be a consideration since she's wanting to lose weight?
Stole my thunder, Janet.
What's that?
Would you guys consider an SGLT2 inhibitor, since we do see some weight loss with that and kind of avoids the GI issues? But I agree, I don't think there's any risk with the diarrhea. Generally, with the slowing down of the gastric tract, we see constipation more commonly than diarrhea, but it is possible to have diarrhea. But maybe an SGLT2 inhibitor, if she is looking for treatment, you can see some weight loss with those. So I think I agree there with Janet that that might be another option to discuss.
Do you think the weight loss is more related to fluid? Because that is always my primary concern, is the weight loss benefit, because it has more of a diuretic effect.
Given her sugars, I'm not sure how much of a diuretic effect it's really going to have, because she's pretty well controlled. So yeah, it won't be a robust weight loss. Certainly nothing compared to what you'll see with Ozempic probably. But I think if she's pushing for treatment and wants something, it may be an option. But yeah, the weight loss would probably be minimal compared to what you might get with Ozempic.
Okay. I also, if her blood sugars aren't high, I don't know how much benefit it will give her from the glycemic standpoint, because you're basically just lowering the threshold within the kidney at which you excrete sugar. So if the blood sugars aren't high, I don't know how much, glycemic benefit she'll have. But so personally, I would probably go with the GLP-1 if she's wanting something.
Okay. Well, thank you. This is helpful.
Well, the other thought was, does she need kidney protection, and would she gain some benefit from being on an SGLT2 inhibitor for that reason? Maybe not the weight loss or the glucose control.
What was her renal function?
It's been pretty normal.
Okay.
I think your last creatinine was 0.85.
Okay.
Her albumin, her diabetic urine just a couple weeks ago was fine. So.
Okay.
But that is an interesting thought, that we're going to have all these other things thrown at her because of the ulcerative colitis. Do we protect her kidneys?
Yeah, I mean, I think a kidney doctor would probably have a different answer than me, but I think probably looking at everything that you have available to you with the BMI, and I think GLP would be my first choice, the Ozempic. There some, I don't feel personally that I see a lot of hypoglycemia with SGLT2 inhibitors necessarily, but I feel like if you're going to compare the two, you'd probably be more apt to see that happening with the SGLT2 versus a GLP. I don't know. Do you agree or disagree, Dr. Quinn?
I think you're kind of splitting hairs there because the risk is so
Yeah.
low with either one of those.
Yeah.
Hypoglycemia. So
Yeah.
And Dr. Rexroad or Janet, did you guys have any other questions about this case in particular?
I can't think of any. Like I say, I just hearing all this has been it's given me a lot to go back and discuss with her and to file away for future reference as well.
That's great. And any other folks from the group or hub members with recommendations, feedback? Alrighty. Well, thank you again, Dr. Rexroad, so much for this case. We really missed having case presentations, and it's just great for discussion and learning purposes. So we so appreciate you guys bringing this case today. And thank you all for everyone in the group for chiming in and giving some feedback as well. All right, so we will go into the didactic portion now. Dr. Turner, I can share screen and pull up your case if you'd like, and then just let me know, sorry, not your case, your PowerPoint, and when you'd like to go to the next slide, just let me know. Thank you.
All right, so I'm going to talk about management of goiters today. Basically, a goiter can be either an enlarged thyroid gland, just a generally enlarged gland. It can be one nodule, it can be more than one nodule. So we'll talk a little bit about how to manage these things today. Next slide, please. And next slide. So what is a goiter? I think I already jumped ahead of myself here and started talking about a goiter. Could you go to the next slide, please? Thank you. So it's basically just an irregular growth of the thyroid gland. And I know I mentioned this, but it can be overall enlargement or just asymmetric enlargement as a result of one or more nodules. Sometimes we consider it a goiter if it's anything that's not a normal thyroid gland. And it's actually recognized as a reimbursable diagnosis by insurance. Next slide, please. So this is a normal thyroid gland, so not a goiter. Next slide. And then, you can see in the photo there of someone's neck that that's obviously enlarged. So that would be considered a goiter. And then the cartoon images below, one nodule, then a multinodular thyroid gland. All of the above are considered a goiter. Next slide. Next slide. All right. So the average weight of a thyroid gland is around 25 grams. I put the measurements in here just more for a reference, because oftentimes the patients will ask, if they don't write it in the ultrasound report, what is a normal sized thyroid gland? So anything between 4 and 6 centimeters in regards to height, so top to bottom, is within normal range. And then they measure really 3 dimensions. So they measure how wide it is, how tall it is, and then front to back. And so the average thickness front to back is about 2 to 3 centimeters. Sometimes people will have what looks to be a goiter, or their neck is just prominent, and it's really just their anatomy. Their trachea sits a little more forward. You may ultrasound it and then be surprised when you see the thickness is within this 2 to 3 centimeter range. Sometimes it's just the anatomy of the person. And then the average width, so side to side of each lobe, is about 1.5 to 2 centimeters. Again, I did this where I already talked about my bottom point already. So next slide, please. So if you look at just worldwide, the most common cause of a goiter, it's iodine deficiency. That's not so much a concern here within the States, because all of our foods are supplemented with iodine. We have, iodine in almost everything we eat. So in the United States, the most common causes would be multinodular goiter, Graves' disease, where you really get the diffuse enlargement of the gland, and then Hashimoto's disease. typically, but not always, it's at presentation, because over time, if you see these folks that have had Hashimoto's for 20, 30 years, their gland is most often atrophied, and it's a very small gland. Some other less common causes, infiltrative disorders, cancer, that would be things like lymphoma or just thyroid cancer in general, and then thyroiditis. Next slide, please. So once you find a goiter, or you palpate it on exam, a palpated nodule, or it's a lot of times picked up incidentally with a CAT scan that someone has in the ER, we want to know, is it causing any problems just due to the size? So I typically just ask patients, are you having any choking sensation or coughing when you lay down in bed at night, or choking sensation when you lay flat? And then the physical exam, if someone has a huge goiter on exam, I'll do a Pemberton sign where you have them hold their arms up for a minute, and you're looking for not only what does their face look like, I mean, is their face getting purple or red, but you're also looking for symptoms. I mean, if you don't see any changes, but they feel like they're being choked, I mean, that's a positive Pemberton. Of course, is there any thyroid dysfunction? So if you find a goiter, even a thyroid nodule, rather than the whole enlargement of the gland or diffuse enlargement of the gland, I always check a TSH, just make sure you know what their thyroid function is. And then the presence of nodules, you're going to find out with a thyroid ultrasound. And then we want to know what the cause is, if there is a cause. So is their gland diffusely enlarged because they have Graves' disease? And that, entails some additional workup. Next slide. So should we worry or should we not? So is the gland causing obstructive symptoms or signs? That is definitely a concern. If they're having trouble swallowing, I'll tell you, I see so many people that report some issues swallowing, and they'll have a less than 1 centimeter nodule. So it's not always causing their trouble swallowing, but it's definitely something that you want to be thinking of and asking them. Any voice changes or hoarseness of the voice, if they're coughing frequently, and then I know I mentioned this before, but any pressure or trouble breathing when they lay flat on their back. Next slide. I did mention this a little bit. I think I have a picture on a later slide, but Pemberton sign. I usually, like I said, I usually have them do this for a minute. If they're comfortable with it, I know everyone's wearing masks. We still have a mask rule in our office, but if they feel comfortable, I'll have them pull it down just so I can see what their whole face looks like while I'm doing this. Next slide, please. So this is a pretty classic image that's used in a lot of our textbooks, but this is a positive Pemberton sign. And basically what happens is, you only have so much space in your neck. And when we raise the arms up, that space gets even smaller. And if you have anything in there that's pushing on surrounding structures, it's basically obstructing the venous outflow from the head. And so, you can see the face gets red, it can get a little bit purple, and that's pretty concerning. For some obstruction within the thoracic inlet. Next slide. And when someone has this, it's a surgical indication. They need to have that gland taken out. I've had people tell me they'll be reaching up in their cabinets at home. And that's actually sometimes how I'll ask them the question. I'll say, if you reach for something in your kitchen or up in a closet, do you feel like you're being choked or feel any increased pressure in your head? And sometimes they'll be able to tell you. And of course, you'll do the Pemberton test. But, so if they're symptomatic at all, then that's a positive Pemberton. Next slide, please. You also want to consider doing an evaluation to make sure it's the thyroid gland. So if the thyroid ultrasound is done, and it shows a normal size, but they're having all of these symptoms, they need some additional workup. So either a swallow study, or, if they have palpable nodularity in their neck, but the ultrasound shows a normal gland, probably want to do a CT of the neck just to make sure, what is going on in the neck. What is the nodularity from? Do they have swollen lymph nodes? Barium swallow or swallow studies, that's usually not ordered by us. Typically, if they're having dysphagia and I look at them and I do an ultrasound and it doesn't appear to be coming from the thyroid, I typically refer them back to their primary provider so that it can be addressed and further workup can be done. Sleep study, et cetera. I know I have those things mentioned there. Next slide, please. So if they have an enlarged thyroid gland, but it's not causing any signs or symptoms, then really it's just up to the patient. I mean, does it bother you cosmetically? If it doesn't, then I just watch it. And if it gets larger, of course, then you reassess that. But I typically reassure the patient, hey, your thyroid's measuring a little bit big, but if it's not bothering you, we can just watch it. It's nothing to be emergently concerned about. Now, if they have nodules, and I'll talk about this on some of the later slides, then those need followed up on. But if they just have a gland that measures a little bit bigger than the measurements I initially gave you on one of the first slides, then really they just need reassurance. Next slide, please. So I know I mentioned this previously, but you want to check TSH to make sure we're screening for thyroid disease in these folks, just because the most common cause of a goiter in America is Graves' disease, Hashimoto's. We want to make sure we're catching those diseases if they occur. So what if there's a goiter and it's not causing any compressive symptoms? Pemberton's not present. So if the TSH is abnormal, you want to investigate the underlying cause and treat that accordingly. But again, like on the prior slide, if the TSH is normal and this gland is a little bit big, not causing any problems, just reassurance. Next slide. So with thyroid nodules, you can see one nodule, you can see multiple nodules. I typically call that multinodular goiter. And that's when the TSH becomes handy, because if your TSH shows that they're hyperthyroid and it's not Graves' disease, then you start thinking about the nodules possibly overproducing thyroid hormone. Next slide. So if you see or you feel a nodule, we want to do a couple of things. We're going to order a TSH. I typically do that before they leave the office. And then I also, by that point, I've hopefully already gotten an ultrasound of the thyroid. But if the TSH is low, whether the T3 and the T4, the actual thyroid hormone levels, even if they're normal or they're elevated, my next step is to consider an uptake and scan to see why they're hyperthyroid. Do they have Graves' disease with coexisting nodules, or do they have one or more of those nodules that can be overactive? If the TSH is normal, they don't need the uptake and scan. That's really the only situation in which I would order an uptake and scan, is if they're hyperthyroid. I don't do it if they're hypothyroid. And the goal is to see which, if any of those nodules are overproducing thyroid hormone. If the TSH is normal and they have a nodule, they just need an ultrasound, no uptake and scan. Next slide, please. So majority of thyroid nodules are benign. About 95% of these are benign. And so I reassure the patients that usually when they come in, I'll tell them, you know, thyroid nodules are really common. We just have to make sure that there's nothing to be concerned about. What I typically tell people is about, if you pull 10 people off the street, at least 2 or 3 of them are going to have nodules. And the majority of the time, they're nothing to be concerned about. The size of a nodule in a lot of cases isn't necessarily where our concern is. We take size and also what the nodule actually looks like. So that's why I have written that here. So the size of the nodule has minimal predictability with respect to cancer risk. It's really the characteristics of the nodule. So you know, you can have huge nodules that are very, very low risk nodules, very low percentage risk that it's cancer. Or you can have a small nodule that has these tiny little micro calcifications on the inside that has a extremely high risk for cancer. So the other thing that people will ask is, if there's more nodules there, does that increase my risk for cancer? And that's not the case. Okay, next slide. So the reason that we care, and again, this is also what I tell people, I say, you know, 2 or 3 out of 10 people will tend to have nodules. And the reason that we care is that so that we don't miss that 5% of the that it is cancer or something to be concerned about. So that's why we have to address it, follow it with ultrasounds. And if it meets criteria to biopsy, we send them for biopsy. Next slide, please. So how do we know if there's cancer in a nodule? I have had cases where patients have been referred here and they've had an uptake and scan. The thyroid function was normal, but the uptake and scan was ordered just to see if the nodule was hot or cold, or I'm sorry, was cold. So typically if you see an uptake and scan and the nodule's cold, that's something that needs addressed. That basically just means that it didn't uptake any of that radioactive iodine. And that's actually more concerning than a hot nodule, where that nodule took up too much iodine and is overworking. So that is not diagnostic of a malignant nodule. So we don't do that. Remember, the only situation where you really think about ordering a thyroid uptake and scan is when you have nodules that you know about and the person is hyperthyroid. Next slide, please. So I think I talked about this a little bit already, but you're not going to do an uptake and scan to investigate a nodule unless you have a TSH that indicates hyperthyroidism. And it's really just to determine the reason. So if you have a patient that comes into your, I'm kind of going off the goiter topic here, but if you have a patient that comes in and they're hyperthyroid and you can start with antibody testing to see if they have Graves' disease. And then if all their antibodies are negative and you really want to determine what the cause is, then at that point, I would typically order a thyroid uptake and scan. So if I have somebody that comes in hyperthyroid, if this helps anyone, I'll tell you kind of what I do. Someone comes in and they're hyperthyroid, I'll order TSI, which are thyroid stimulating immunoglobulins. And then I'll also order thyrotropin receptor antibodies. And a lot of times I'll do TPO antibodies as well, because sometimes when Hashimoto's thyroiditis starts, they can become transiently hyperthyroid before becoming hypothyroid. And then when those antibody levels come back, if those don't give me my answer, then I'll start thinking about doing the uptake and scan. Next slide, please. So the ultrasound is the #1 way to look at a thyroid gland. Even if a CT scan shows you a thyroid nodule, the best way to assess those nodules is an ultrasound. It allows us to characterize the nodules and get a better measurement. You know, the CT scan is good for looking at bones, so it really can't characterize those nodules for us, but it's helpful when they identify them, when we otherwise wouldn't have known they were there, but the ultrasound is the best way to characterize the nodules. The only time I order a CT scan after an ultrasound of the thyroid is if they have a huge gland and I'm worried that it's gone substernally, just to maybe help the surgeon out. Or if I'm trying to decide, do they need to go to a surgeon or not? The ultrasound really can't go through the ribs or beneath the clavicle. And so the CT would be the best imaging in that case. Next slide, please. So what if the ultrasound doesn't show any nodules? Then you're just going to follow them going forward. If you do an ultrasound of the thyroid, even if the gland's a little bit big, you don't have to continue to serially monitor that. You can just do exams every time they come into your office. The nodules will, if they do have nodules, they'll need followed up on, but if they don't, you don't have to keep doing images going forward unless they develop new symptoms or you feel a new nodule. Next slide. So what if the ultrasound does show nodules? Next slide. So here is a nodule that is measuring 1.36 centimeters. And this nodule, I would be worried about. There look to be microcalcifications within the nodule, the echogenic areas that look a little bit brighter than the rest of the tissue. This nodule is also what I would classify as a hypoechoic nodule, meaning when I look at that nodule versus the surrounding thyroid tissue, that nodule is hypoechoic. It's darker than the rest of the tissue around it. Next slide, please. So we always, if we order thyroid ultrasounds, we always look at our own pictures as well as the radiologist report, just so we can see what the characteristics are. So we want to know, how big is that nodule? What does it look like? And then we use our American Thyroid Association guidelines to determine whether the nodule meets criteria to biopsy it or not. Next slide, please. So, perfect. Oh, yeah. Could you go to the next one, please? Thank you. So you all can actually look this up on Google. I would actually encourage it. It's really helpful to be able to look at this table. If you just type in ATA nodule guidelines into Google and then click images, this will pop up. So from top to bottom, these are more concerning to less concerning. And also you can just take the slide from this presentation and use it too. So up at the top, these are going to be your high suspicion nodules. So 70 to 90% chance of it being malignant. These will be, the majority are hypoechoic, and then you'll see the very first image is microcalcifications where there's those little echogenic foci within the nodule. Those are concerning. That needs biopsied when it hits a centimeter. So does the next line. Those are just hypoechoic nodules without any calcifications inside. Excuse me. And that also needs biopsied at a centimeter. But then the less concerning the nodules as you go down, the higher the size threshold to biopsy. So these low suspicion nodules, those are typically hyperechoic or isoechoic. So hyperechoic means it's brighter than the surrounding thyroid tissue. Isoechoic, it looks the same color. That's your low suspicion nodules. And I tell people that's about a 90 to 95% chance that it's nothing to worry about. But if it hits a centimeter or larger, we biopsy them. And then the very low suspicion nodules, if you ever see a nodule described as a spongiform nodule, it almost looks like a dish sponge that you kind of cut and took a look at on the side. It looks like you could smash it down and it would kind of disappear, and then you let it go and it pops up and it looks like a sponge. So those are low suspicion nodules, and we usually don't biopsy those until they hit 2 centimeters or greater in size. Does anyone have any questions about this slide? I always think it's really helpful to look at, and like I said, it's really easy to pull it up. Sometimes I'll even show patients in the room if they have a lot of questions, or if they seem hesitant about not biopsying, I'll pull it up and show them what their nodule looks like, and then what this table looks like, and where their nodule fits on the table. Okay, and then of course the benign I didn't really talk about. That's just a simple cyst. There's no echogenic material within the very bottom photo, and you don't even have to FNA that. You don't have to biopsy it. Now, sometimes people will say, oh, I don't like the way it looks on my neck. You can send them to get it drained, but it can fill right back up. It's almost like a cyst anywhere else on the body. Like if you have a cyst on your back, if you don't take out the actual cyst, it's just it potentially will fill right back up, but there's no indication to FNA it for, ruling out a malignancy. Next slide, please. All right. So if the report that you get back from the radiologist shows multiple nodules and you can only biopsy one, how do you choose? Next slide, please. So deferred biopsy for 6 months, biopsy the largest nodule or biopsy the nodule that has the highest risk. Does anyone want to chime in with what they think? Hopefully I've already led everyone into the answer, but the answer here is to biopsy the nodule that has the highest risk. I guess I'm going to ask the audience this. When you all get thyroid ultrasounds, are you able to see the pictures? No? Okay. That I know makes it a little more difficult, but I find the radiologists are pretty good with, telling you which one looks the scariest, which I think is nice in that kind of a situation if you can't see the pictures, and that's also helpful. Their risk classification system is unfortunately a little bit different than ours. I think it follows the same general idea, and hopefully in the future we'll maybe share a scoring system for these nodules, but right now they use TIRADS and it's a little bit different. But so sometimes they'll give you the TIRADS category, and then they'll say FNA recommended. So if you're not able to see the images, I think sometimes you just kind of have to go with what they say. Next slide, please. Next slide. All right, so, if you can see the images, you can tell them which one to biopsy. They changed the order here within our system. excuse me, to where you have to specify which one you want biopsied. You can't just say biopsy the biggest nodule. So, and I think I mentioned this before, but that nodule might be one of those spongiform nodules that's a lower risk in the low risk category, but then you're missing the one that's in a higher risk category. Next slide, please. Next slide. Okay, so FNA results, when I'm sending someone for an FNA, I tell them you could just generally get 4 different results. So benign is going to be the most common. One, the sample size is insufficient. No matter how good the person is doing it, which I tell the patient this, no matter how good the person is doing the biopsy, there's always a chance you just don't get a good enough number of cells to make a diagnosis. So that's one potential. The other potential is that it's suspicious for, or it is cancer. And then the last one that I tell people about, this is what I really spend a little more time on so that they don't panic when they see it. When I get an FNA result that shows atypia of undetermined significance, I tell the patient it's just a fancy term for the cells look a little funny and we're not sure what that means. So they get sent off for additional genetic testing to see if there's any mutations that are commonly seen in different thyroid cancers. And when they send that off for that reflex, Afirma testing is the one we use here. It takes about 1 to 2 weeks for us to get results after that. So I'm going to go back up to the top here and just talk about when to repeat. So if you get a benign result, I typically would just recommend repeating the ultrasound in a year and make sure it hasn't grown at all in size. If the sample, if you get a sample that's insufficient, so there weren't enough cells to make a diagnosis, depending on the risk of the nodule, I almost always recommend that we repeat the FNA. There's really not a great set of guidelines that says when to do it. We usually choose 1 to 3 months. You don't want to send them the next week because if they had some bleeding inside that nodule, you might just be biopsying and get a bunch of blood back. If it's thyroid cancer, we send them right away to either ENT or endocrine surgery. And then I know I mentioned this before, the atypia of undetermined significance gets sent off for gene testing. And then, you know, if it comes back suspicious, they either get half their thyroid removed or the whole thyroid, depending on if there's other nodules on the other side as well. Next slide, please. So when should you order an ultrasound? It's not part of the standard evaluation when you diagnose somebody, say, with hypothyroidism. So if you diagnose somebody with hypothyroidism, they don't need an ultrasound. It's really only if you feel a nodule or a nodule is incidentally discovered on something like a CT scan. Next slide, please. And then just the heterogeneous versus homogeneous terms on the ultrasound report. Could you go to the next slide, please? Heterogeneous, I usually tell patients when I'm describing it, you know, it looks more coarse. So if you're looking at just a solid color, you know, I think that last image that I used where it had a nodule there, the rest of the thyroid tissue around it was pretty homogeneous. So it's more smooth, one generally solid color. Heterogeneous, you can see a lot of times with different thyroiditis. So you can see it with Graves or Hashimoto's. The gland is undergoing destruction and it almost just looks kind of chewed up in places. And basically that's what that means. It's a little bit coarse. Next slide, please. Any questions?
Thank you so much, Dr. Turner. You did a wonderful job breaking that down. It's such a complex discussion and you did a wonderful job. So thank you.
Thank you.
Any questions, comments from the group?
Does anybody have any cases they're not sure what to do with in regards to nodules or any thyroid things?
I'm just curious, do you have somebody out there who specializes in thyroid or parathyroid surgery?
We do actually. We have a couple endocrine surgeons that we send people to. One of them just kind of subspecialized on his own. The other actually did an endocrine surgery fellowship. I'm happy to give you their name if that's what you're looking for.
Yeah, that would be. Thank you.
Yeah, sure. The ENT does a lot of these too, but when I have parathyroid patients, I most often refer them to Dr. Lopinto. Her first name is Melissa, and then the last name is Lopinto.
Okay.
And she's endocrine fellowship trained, or endocrine surgery fellowship trained.
Dr. Turner, you're welcome to email me any information as well, and I'm happy to pass along to Dr. Rexroad for you.
Okay. Okay.
Thank you.
Sure. Yeah, you're welcome.
And Dr. G chatted in. Thanks for a great lecture, Dr. Turner.
Oh, thank you. Thank you for listening.
Any other questions, comments?
Thank you for your case, Dr. Rexroad.
Yeah, I just thought it was, it had some interesting wrinkles, I thought.
Yeah.
So,
Definitely.
and yeah, I definitely learned some things in the discussion, so that was
Good.
good.
Okay, if there is nothing further, as always, you can reach out to myself or Elizabeth, and we'll make sure to have any questions addressed. The only announcement is that next session will be on October 12th, and Dr. Nadia Barghouti will be presenting on hyperthyroidism. Keep an eye out for that reminder. Thank you again, Dr. Rexroad and Dr. Turner, for the case presentation and the education portion didactic. Thank you all so much, and we hope to see you all next time. Take care.
Thank